us on the map. Mr. Caruana leading the beat. Australia global rank 6. Feeling the heat like immortality.
All right, so for our second group, we're looking at groups experiencing health inequities here in Australia. We are going to look at rural and remote populations. Now, a lot of this data is actually going to coincide and overlap when we looked at First Nations people, because we know that a majority of First Nations peoples that do suffer from inequities live rurally and remotely. So hopefully this will cut down a little bit on the amount of data and trends you need to remember for answers, because a lot of the time you can substitute one for the other. And just know that if you are a First Nations person living rurally and remotely, basically all of these numbers increase further. But we went through that in the previous video. So today, just rural and remote populations, okay? So first of all, what does the data tell us, all right? I did want to caveat this by, I'm just assuming you guys know what a person who is living rurally and remotely is. So basically, it is somebody who does not live in a metropolitan area or near a large city, okay? And then obviously, the further away you get from metropolitan areas and large cities increases the amount of remoteness that you have. So you can live rurally, and then so rurally is basically defined as small towns. We are semi-close to larger cities that are west, okay, of Australia. And then from there, if you keep going, you become remote. And then if you keep going, you become very remote, all right? So we don't break down the data into rural, remote, and very remote people. We just have rural and remote people. So there are currently 28% of Australians, according to statistics, so there's probably more, because remember, this is all done on data that people contribute. So these are the people that we know of. There's probably more, all right? So 28% of Australians living in rural or remote locations. There is 26% of that is made up of rural and 2% remote or very remote. And I just thought I'd just break down what we're talking about here, because 2% doesn't really sound like a lot of people, all right? However, 26% of people living rurally is 7.2 million Australians, and 2% living remotely or very remotely is 554,000 Australians. That's a lot of people, all right? So imagine if all of those people are going to suffer from all of these things, all right? That is huge inequity, huge burden in healthcare. So as remoteness increases, mortality rates go up, morbidity rates, so disease goes up, and life expectancy reduces, all right? So if you are living rurally, you'll have increased and decreased numbers of these, and then if you go to remote, it gets bigger and bigger and bigger, okay? So imagine like a graph, and then the further out you go, basically the worse off you are statistically. So what are we actually experiencing in these problems? So we've got 3.2 higher disease burden than metropolitan populations, all right? So that means that if there are 100,000 people suffering from asthma in Sydney, then according to the data, there would be 320,000 people suffering from asthma in rural and remote populations, all right? So significantly higher. If you live remotely, you are 2 times more likely to die from preventable causes, all right? There is a 2 times higher hospitalization rate. This one I found very concerning. 24 times higher domestic violence hospitalizations. So people who are going to hospitals, if you can get to a hospital in a rural remote location, 24 times higher domestic violence rates. That's huge, all right? Coronary heart disease, 2.2 higher rates. Self-harm suicide, we've got a 2 times higher rate. 6% higher rate of obesity compared to the cities. I also found that one interesting because we talked about obesity being like a modern disease because we have access to foods and all this kind of stuff, etc. You live rurally and remotely, you don't have a Macca's and a KFC on every corner like we do here in metropolitan areas, but there's still higher rates of obesity. So I thought that was interesting. 30% higher smoking rates. Pregnant, and lastly, this is concerning, pregnant mothers are 5.5 times higher rates of smoking while in term. So that's really concerning, okay? And then you can imagine that then has the ongoing effect as to infant mortality rates. So these are just some data and trends looking at people who live rurally and remotely. Now we'll go through some determinants, so sort of why. So interaction of the determinants, right? So what is it actually about people that live rurally and remotely that causes all that data that we went through to be so poor? So let's look at environmental, all right, which is the big one, and it leads into everything else, and then it's a big cycle. So environmental, so distance. Distance is the key word here. Distance leads to geographic isolation, which therefore leads to poor internet access, poor access to health infrastructure and services, not only hospitals, but GPs, specialist services, dentists, etc. Okay? Then we look at socioeconomic. So distance also therefore limits access to education facilities, which limits job opportunities. Consequently, rural and remote populations have lower rates of secondary education completion, so that's like high school, tertiary education completion, so not only university but TAFE as well, and therefore higher rates of unemployment and lower median income too. So all of the people living, not all the people, significantly populations living rural remotely don't have the attained levels of education required to go on and get jobs. But also, because you live rural remotely, those jobs just aren't there, all right? The only real way to break this cycle is for people who live rurally remotely to move to metropolitan areas and therefore live the metropolitan life. Socioculturally, due to this above, individuals now live with chronic stress, okay? So think about it. If you lack education, you can't feed your family because you don't have a job or your job doesn't pay enough to pay for all the things, that's stressful, all right? And because you're living with stress all the time, those people therefore experience higher mental health issues, higher rates of self-harm and suicide rates, along with higher domestic violence, which we went through in the data section. As a coping mechanism, individuals turn to risky health behaviors such as increased alcohol consumption, increased levels of smoking, increased substance abuse, etc. All right? Because there's now these increased levels of risky health behaviors, we have the population living remotely having higher rates of CHD, cancer, respiratory issues, okay? All the things that are killing Australians, these guys suffer way more of. And therefore, due to their location, they can't access health infrastructure and services, and the cycle just keeps going, all right? It's like the circle of life, except not life, the opposite, all right? Distance leads to this, leads to suffering, therefore, etc. So the cycle must be broken, and unfortunately for rural and remote populations, the obvious answer is to not live rurally and remotely, okay? But that's hard. You can't just like pick up your bags one day and just move to the city. I mean, there's plenty of movies about it, but life isn't a movie. But obviously there are issues. The government is very aware of this. So the government is trying to do things to not move these people to the city, but we're trying to move infrastructure, specifically health infrastructure and education infrastructure, out west, which we'll go through now. So just before I touch on what can we do to fix this, I figured I'll just really summarize what is actually going on here, what is actually underpinning all of these inequities that people living remotely have. So just to summarize it all, people who live rurally and remotely, they have limited access to healthcare, primary healthcare, but also extra services, lower usage of chronic disease management services, lower preventative screening for cancers, lower Medicare usage, which is actually recorded. And just a side note that there's a significant population cannot access primary care under a 1 hour drive, okay? So if I hopped in my car right now and I drove in any direction for an hour, how many doctors, like GPs or medical clinics or hospitals do you think I would drive past? At least 100 in an hour, I reckon. Easily 100. But there are a significant population living remote, they will drive for an hour and they will pass 0, all right? Hence, that's a big one for the inequities. There's actually declining health professionals working rurally and remotely. So the government does try to incentivize nurses, doctors, specialists, etc., to move out west and work rurally and remotely. However, that number of people, despite the government's incentives, and we'll go through that soon, is going down, all right? People don't want to work there. And generally, overall, on a person-by-person basis, there is less funding for healthcare, okay? Because if the government was to put, let's just throw some random numbers out, $1 million into healthcare here in Newcastle, $1 million isn't a lot of money really, but $1 million would service a lot of people. If they were to throw that same $1 million into X location, rurally and remotely, how many people are actually going to be able to access that $1 million? It could be under 500 people, like depending on where it is. Like Australia is a massive country. So yeah, the funding sucks. But you can't just pump all the money rurally and remotely, because then you're going to leave people living in metropolitan without proper care, and then, yeah, I don't know. It's tricky. It's a tricky one, all right? Could just get all the rural and remote people to live together rurally and remotely, but, that's not going to happen either. That's not a solution, by the way. Don't write that down. That's just me talking. Okay, so what can be done? What can we do to try and minimize the inequity between people living in rural and remote populations and metropolitan areas? So first of all, we need to strengthen the primary care workforce, okay? So dedicated funding for training rural GPs with specialized skills, such as the Rural Generalist Program, which currently runs, all right? So I said on the previous one that we actually have a decline in the amount of specialists and doctors who are working rurally and remotely. So we need to enhance that, get more people out there. If there's more people out there working in clinics in small towns, then more people can access healthcare, and therefore it's going to reduce the travel time that it requires people to get to a doctor, all right? So instead of, driving for a whole hour and visiting no doctors, maybe they might be able to drive an hour and visit 2. That's great. That's like a 200% increase in the amount of medical services available. And so this Rural Generalist Program basically helps fund GPs through medical school, but also they don't just graduate as a general practitioner GP, they actually come out with some specialist skills as well. So not only can they just do GP stuff, they can also, so diagnostics, but then they may also have like a cardiovascular specialization certificate underneath them, so then they can help with CHD, for example. Going along with this, we probably need to look at implementing team-based succession planning with a network of remote supervisors to support new GPs in isolated towns. So remember that the number of GPs working in isolated towns is going down. That's because they feel like they don't have the support. They can't refer people to specialists because there's no specialist there, or maybe they can't just you ever been to a doctor and then a doctor asks you a bunch of things and they just leave the room, they go talk to their colleague and then they come back. Well, they can't do that in remote towns. But imagine if there was this network, okay, where they could just call a person and be like, hey, I'm at this clinic, just need some second opinion, blah, blah, blah. So there might be one, remote supervisor that oversees 10 different clinics in a rural and remote area. So they all are sort of working together as a team. So even though they're isolated, they feel like they're working in a team environment, and that is more likely to retain people working in healthcare. A big one, which is the obvious answer, is expanding telehealth, and expand it for immediate consultations. So a lot of the time, if you want a telehealth appointment, you've got to go on a wait list for maybe a week or maybe weeks in general. Imagine if there was just a clinic, like a rural and remote telehealth clinic, and it just had 10 doctors. They're all at desks, okay, and they're all at one place, and you could just call up and you could, be on hold, and you may have to be on hold for 30 or 40 minutes, but after that time you get a doctor and then you can talk to them about your issues. That would be great, all right? Yes, it's probably going to be costly, but it's probably going to be less cost than building new infrastructure. So that's definitely an option, but once again, to have this, you need to have more training, and so we need to incentivize people to train. They're looking at the use of AI for remote diagnostics, such as AI vision screening. So there's tools currently where through the use of AI, they can determine whether certain issues require follow-ups with specialists, okay, or not, all right? Obviously, this is developing, so it's not really a solution, but it could be a solution going forward. More self-collection and screening programs available to rural remote people. So there's a bowel cancer one where, you take a fecal sample and you send it off in a box somewhere, and then they let you know how that is. So there's cervical cancer ones where women will take swabs and send that off for diagnostics. So imagine if that was more readily available, okay? That would definitely help. Community-based initiatives such as community first responders, which train members in emergency healthcare to stabilize patients until distant ambulances arrive. So this is sort of like a first aid course, much better, okay? So basically, if everyone in a community, in a remote town well, not everyone, but a lot of significant population were trained in how to care for people who have had, a heart attack or a stroke or suffering, a diabetic high or low or any concern like that, then community people should feel empowered to look after those people while the ambulance gets there, as opposed to just sort of sitting around and not doing anything productive. A couple other things, we've got mental health community focused programs such as Outback Futures, because we know that people who live remotely have significantly higher rates of mental health problems. So delivering mental health programs like support networks, discussions, etc., could be like in person, or it could be done via telephone, or if you had an internet access. But the program is tailored for people that live rurally and remotely and delivered by people that live rurally and remotely, so they can actually talk about issues that are affecting them, as opposed to someone from the city telling them about mental health problems, from someone who lives 950 kilometers that way. And then finally, maybe looking at a different fit-for-purpose funding model, all right, which prioritizes retaining staff in rural and remote locations, as opposed to the government going, oh, okay, well, look, if we want to put a new hospital out here or a new GP clinic, medical center out there, it's going to cost, $1.7 billion, and we just don't have that funding, and it's only going to service, 50 to 100 people, and that's just not worth it. So that's why the government doesn't do it. Well, maybe the fit-for-purpose would go, okay, well, we need to service these 50 to 100 people. What's actually going to be the best cost measure to address that? Well, okay, let's fund 2 people through med school and put them up in employment out there, and that's going to cost, maybe $200,000. So literally a drop in the ocean of the initial thing, and all of a sudden 100 people have healthcare as opposed to none. So they're just some ideas as to what can be done, all right? And some of these things, like with the examples, are being done, but we're not seeing the fruits of that yet, but maybe we will in the future. So that's the end of the video, looking at why or what rural and remote populations are experiencing inequities from here in Australia, the reasons for it, and what could potentially be done to bring up their health status to more like people who live in metropolitan areas. Thanks.